to invite our second speaker, Dr. Kunal. સપન સર માટે મેં એવું કહ્યું કે સર સાયન્સને ઘોળીને પી જાય છે, તો હું કદાચ કુણાલ માટે એવું કહીશ કે સાયન્સને ઘોળીને પી જાય છે પણ એ ગોટલી પણ ખાઈ જાય છે. સો Dr. Kunal is a consultant clinical immunologist and rheumatologist at Zydus Hospital, Ahmedabad, and he has done his DM from KGM in Lucknow. He has multiple publications and research articles. Over to you, Kunal.
Thank you so much, and thanks to the organizers for a very warm invitation to Rajkot. And sir started with a shairi, so I'll try to do the same. Now my topic is when to call a rheumatologist in the ICU, and the shairi goes as आज बादलों ने फिर से साजिश की है, जहाँ मेरा घर था वहीं बारिश की है. आज बादलों ने फिर से साजिश की है, जहाँ मेरा घर था वहीं बारिश की है. अगर खुद ही को जिद है बिजलियाँ गिराने की, तो हमें भी जिद है वहीं आशिया बनाने की. So you often don't recognize rheumatologists as ICU doctors, and we do deal with a lot of emergencies overhand. So coming to the general principles, the most common reason a patient with rheumatological disorders would be admitted would likely be an infection. And most common system that is usually involved in our set of patients is the lung. Most common conditions, as you all might have seen, are lupuses, rheumatoid, vasculitis, systemic sclerosis, and myositis. And serological testing might be positive, might be negative, sometimes be false positive in these set of conditions. So a clinical context is very important. Inflammatory markers like ESR and CRP might not be as helpful as one might think in an ICU setting. So I have a case-based discussion with you all of you today, and I'll be discussing a few set of cases as I go along. So we have a 26-year-old female who had come to us with polyarthralgia for the last 6 months and was on alternative medications for her therapy. She came to us with fever and myalgia, with a hemoglobin, that is, she had anemia, leukopenia, thrombocytopenia with elevated renal functions, and a urine microscopy showing proteinuria. This was treated as UTI by an outside physician, and her fever persisted. She was given further antibiotics, transfusions, B12 therapy, and further on a bone marrow biopsy was done, which was showing reactive hyperplasia. She was admitted to critical care with bleeding manifestations, petechiae, pervaginal bleed, and jaundice. There was persistent anemia. Now there was lymphopenia instead of leukopenia, and there was severe thrombocytopenia, along with liver dysfunction also that happened this time. The creatinine had increased significantly, and the procalcitonin was positive, suggesting an infection. Her fever workup was grossly negative, but a blood culture grew E. coli, and she was given appropriate antibiotics for it. So now you had a young female who had arthralgia, lymphopenia, thrombocytopenia, anemia, that is the pancytopenia spectrum, and her autoimmune workup showed that she was 4+ homogeneous on ANA. Her dsDNA was very high titer positive, and she had autoantibodies and complements to suggest an active lupus. She was given, since she was in active sepsis, the next best modality when you are in doubt what to give immunoglobulins, and she was given that. But then she had respiratory distress, had an episode of cardiac arrest, was revived, was intubated, and bronchoscopy was done that was showing active hemorrhage, and a CT was done that was showing diffuse alveolar hemorrhage. Again, a dose of IVIG was given, followed by 1 milligram per kilogram of prednisolone. The platelets didn't respond to the extent we would have wanted them to be, and though her hemodynamic status improved, she continued to have diffuse alveolar hemorrhage along with a non-sustained increase in her platelets and a prolonged APTT. So we did the antiphospholipid antibodies, and they came positive. So she has a multi-system, multi-organ dysfunction and a positive antiphospholipid antibodies syndrome. So this is a young lady who has features of connective tissue diseases, has infections in the bloodstream, has kidney injury, hepatic dysfunction, diffuse alveolar hemorrhage, thrombocytopenia, with rapidity in onset, positive autoantibodies, and positive antiphospholipid antibody syndrome. So this is what you would call as a catastrophic antiphospholipid antibody syndrome that has not responded to your classical immunosuppression. He was, despite some reluctance from the critical care, started on heparin. Now you would think that it would be counterproductive to start a patient who's bleeding profusely from his lungs on heparin, but heparin has additional properties of immunomodulation in patients with catastrophic antiphospholipid antibody syndrome. And the ET bleeding stopped within 36 hours. Her platelets progressively improved. Her organ dysfunction recovered. Her hemodialysis was continued till her renal recovery. And she was discharged on mycophenolate, as Sir said, is the go-to drug for these days, prednisolone and anticoagulation. She had a renal flare in between with lupus nephritis. She was given rituximab and MMF and is all well till March 2025 when I saw her last. So what is catastrophic APS? If you have more than 3 organs that are involved within a week in presence of antiphospholipid antibodies, and you have histological evidence of small vessel occlusion, you call it as catastrophic APS. It can be the presenting manifestations in almost 50% of APS patients. Females are much more common. The common triggers for CAPS are infections, surgery, and malignancy. Infection as in this case. And often this can occur both in primary antiphospholipid antibody syndrome and secondary antiphospholipid syndrome also. And the recurrence is not as high, but it can still recur commonly. The common organs that are commonly involved are renal, platelets, and lungs. The next common, it can also involve the brain, heart, and skin. And as compared to other differentials of microangiopathic hemolytic anemia, that is the DIC, where you have significant alterations in the coagulation profile, you would have just an increased APTT here, and you wouldn't find gross evidences of schistocytes in your blood smears as you would do in case of TTP or HUS. So, and your serology would be positive here, whereas in case of TTP, you would have low ADAMTS levels. CAPS and DIC can often coexist, and a definite diagnosis is often challenging, where response to heparin can be an important clue. The management for CAPS involves heparin along with either plasmapheresis or IVIG and steroids. This is the triple therapy that in guidelines has a very strong level of evidence. And you have to do a prompt treatment of whatever infection that caused it, minimize interruptions in anticoagulation, and maintain an INR that is in therapeutic range. So instead of an end of take-home message, I'll give a take-home message after every case that I present. So think of antiphospholipid antibody syndrome if you have venous thrombosis, especially with thrombocytopenia, in a young patient with coexistent arterial thrombosis, someone who's had history of recurrent abortion, even someone who's had pregnancy-induced hypertension or IUGR in the later half of pregnancies, and late pregnancy fetal losses. 50% of APS is associated with connective tissue diseases, and lupus can have APS in 30 to 35% patients. Think of CAPS if there is multi-organ dysfunction. This might be an initial manifestation in half of these patients, and high mortality if heparin is not given. You have to give, along with it, IVIG, corticosteroids, and another immunosuppression. Mainstay of treatment still remains anticoagulation using warfarin or heparin. We would usually avoid DOACs like rivaroxaban, especially in patients who have arterial thrombosis or are multi-autoantibody positive. So coming to the next case, we have a 52-year-old male who has hypothyroidism, is on Thyronorm about 50 micrograms, is a known smoker for the last 40 years, and has come to us with complaints of bilateral lower limb and upper limb purpura with arthralgias in the wrist and knees. Since he was all well in the 5 years in between, but now have been having recurrent purpuras in bilateral upper limbs and lower limbs and recurrent episodes of hemoptysis. In February, now he had sudden onset breathlessness on exertion, and he has a fall in hemoglobin along with active sediments in the urine with X-rays and CT suggestive of diffuse alveolar hemorrhage. So this is what his CT looked like. There are fluffy opacities on bilateral lung fields, and peripheral smear did not show cystocytes. The DCT and ICT was negative. Infection workup was again negative, and the ANA, ANCA was positive. along with the MPO that was more than 100 units. So this is what your classical ANCA-associated vasculitis is. And coming to another case, because this is again a similar presentation, you have a chronic smoker who is a known case of hypertension that came with cough with mucoid and bloodstained sputum. She has shortness of breath along with significant weight loss and fever. This happened only over 1 month, and there is worsening creatinine, tachycardia, severe hypoxia. He came to us on NIV with a very low hemoglobin, altered renal function, high CRPs, and a significant hematuria. His anti-GBM antibodies came positive, and the ANCA was negative here. Here again, you can see the extent of involvement that is there in the lungs. The renal biopsy here showed the crescentic glomerulonephritis, as you would have expected. So diffuse alveolar hemorrhage with or without renal involvement is a rheumatic emergency. Almost 30% of patients might not have hemoptysis. They might just present to you with low hemoglobin. Look for possible rashes, palpable purpura, active urinary sediments, mononeuritis multiplex, and evidence of focal ischemia. A CT chest with a bronchoscopy will help you in differentiating it from infections and other causes. You have to send a plethora of autoimmune serologies if you are thinking this is an autoimmune diffuse alveolar hemorrhage. In principle, you should send an ANA, an antiphospholipid antibody profile, an ANCA, and an anti-GBM if you are suspecting a patient to have DH. Ideally, obtain tissues. If involved kidney, it is the more likely organ that will give you more information as compared to the lungs. The most common causes for DH or pulmonary renal syndrome is ANCA-associated vasculitis, the 3 subtypes. This is usually followed by anti-GBM disease or good pasture syndrome. Even diseases like cryoglobulinemia and IgA vasculitis can sometimes present with diffuse alveolar hemorrhage or pulmonary renal syndrome. Drugs can sometimes cause. The autoimmune diseases of importance are lupus, and sometimes these might present with polymyositis or dermatomyositis and other diseases. You also have to rule out a possible TTP, HUS, and antiphospholipid antibody syndrome, as we did talk earlier. There are infections that can cause diffuse alveolar hemorrhage. CMV is again an important cause that can mimic diffuse alveolar hemorrhage renal involvement. Drugs including hydralazine, propylthiouracil, etc. can present it. And there's something called as idiopathic pulmonary renal syndrome that can also happen. There can be mimics like pneumonia with renal failure, sepsis with DIC, metastatic bacterial infections, and infective endocarditis. And we have been fooled with infective endocarditis many a times because you can have multiple autoantibodies positive in these set of patients. Treatment would involve what disease you are finding. All of them would actually need good going immunosuppression. Sapan sir has covered all of this in detail. I'm not going into much detail of this. But the take-home point for a patient who has pulmonary renal syndrome is, if you see a fall in hemoglobin with pulmonary symptoms along with renal failure, suspect someone to have a PRS. The major causes include ANCA vasculitis and anti-GBM disease. Always, always, always watch out for infections. These could be concurrent or in isolation. And you could have lupus with DH, which usually has a very bad prognosis. You have to have a high index of suspicion for catastrophic antiphospholipid antibody syndrome. And a pulmonary renal syndrome should be treated with high doses of steroids and other immunosuppressions. So the next is a 38-year-old female who has ITP and has features of the diagnosis that she came was query lupus, query polymyositis. She had an upper respiratory tract infection, and over the last 3 months her status has progressively declined. She has progressive shortness of breath, increased weakness, significant weight loss, and she has progressed to be bedbound. She came to us with a worsening respiratory status, was intubated, put on ECMO. Her WBCs were okay, there was low hemoglobin, the CPK was very high, the inflammatory markers were elevated. You did an extensive infection panel that came out to be negative. Her antibodies were positive for PL12 and Rho52. The rest of the antibodies were negative. The ANA was positive. Her EMG is showing of myositis, and an HRCT is suggestive of an NSIP with OP pattern. So her diagnosis came out to be an anti-synthetase syndrome that was PL12 positive along with myositis and ILD. So what is rapidly progressive interstitial lung disease? So this is a subgroup of interstitial lung disease that progresses very fast, either from room air or baseline oxygen requirement to high oxygen requirement or intubation within days to weeks. You have to rule out alternative causes like heart failure and infections. Progressive pulmonary fibrosis or progressive fibrosing ILD is a different entity as compared to RP-ILD, and RP-ILD commonly develops in patients who have myositis. So the characteristic pattern is more of diffuse alveolar damage, that is DAD, as compared to the classic NSIP or NSIP-OP patterns. What is classical is if you have patients who are positive for anti-synthetase antibodies, MDA5 or Rho52, if you have elevated levels of CRP, LDH, lymphopenia or ferritin, and if your CT is showing lower consolidations along with ground glass attenuations or random GGAs, all of these patients are at high risk of developing RP-ILD. So the classical pattern would be involvement of lower lobe consolidations along with GGAs, subpleural non-segmental GGAs and consolidations in randomly distributing areas. How do you treat these? So you treat them as sir told, if this is a rapidly progressive ILD with either MDA5 positivity or an anti-synthetase positivity with Rho52, you treat them with a triple therapy. The triple therapy is usually with IV glucocorticoids and a combination of these drugs, a combination of rituximab, cyclophosphamide, IVIG, MMF, a CNI or a JAK. You can choose any of these two usually, and you have to be very aggressive in therapy with these set of patients. Sorry. So the take home points again here would be, it is a leading cause of death in patients with myositis. It is important to detect RP-ILD early with HRCTs. Be cautious if you have anti-MDA5 positivity or anti-synthetase syndrome antibodies. The anti-synthetase syndrome antibodies would be anti-Jo1, PL7, PL12, OJ, EJ and all of these. And if you have high levels of CRP, high levels of ferritin, LDH, if you do a KL6 and that is also elevated, if you have lymphopenia, lower lobe consolidation with ground glass attenuations or random GGAs, these are all risk factors that the patient might go downhill anytime. Upfront triple therapy combination is what is recommended, and you need to monitor these patients for rapid progression with HRCTs, PFTs and ambulatory desaturations. Sorry. So the next patient is a 29-year-old female who has had Raynaud's for the past 1 year, is currently pregnant, and she delivered her child at 36 weeks because of premature rupture of membranes. On postpartum day 12, she developed cough and orthopnea. This was suspected to be viral asthma and was treated with steroids, and what it led to is a severe respiratory compromise along with severe hypertension, LV dysfunction. She had some features of early diffuse systemic sclerosis. She had sclerodectomy, skin thickening and GERD. She had fall of hemoglobin, creatinine that increased, thrombocytopenia, and her RNA polymerase was positive along with schistocytes. She was started on ACE inhibitors along with beta blockers and tadalafil. Respiratory support was given and was put on hemodialysis, and this patient in turn was diagnosed with systemic sclerosis with scleroderma renal crisis along with cardiomyopathy. Very important aspect in treating patients with systemic sclerosis is not giving them high-dose steroids, because in a lot of studies it has been proven that if you're giving high-dose steroids beyond 15 milligrams per day, you are at a much higher risk, almost 4 times higher risk of developing SRC versus controls. And even if you are giving, those patients who have SRD have been on much higher doses of steroids as compared to those who have not. So usually don't go beyond 7.5 or 10 milligrams if steroids are extremely needed in patients with systemic sclerosis. Usually, if you can perform a biopsy in these set of patients, you could have alternative causes like TTP, vasculitis or glomerulonephritis. Coexistence of ANCA vasculitis with systemic sclerosis is a known fact. The long-term outcomes of systemic sclerosis, renal crisis is usually not that good. In some case series, it has been found that systemic sclerosis renal crisis actually has a worse outcome as compared to patients who have malignancies, and hence you have to be very careful in these set of patients. Prompt diagnosis and management can help these patients a lot. What is important in guidelines for therapy of this patient is that ACE inhibitors should be initiated and continued in all patients that are diagnosed with SRC. Other antihypertensives should be required and initiated for control of hypertension. Glucocorticoid treatment should be minimized as far as possible. You need to have a low threshold of starting renal replacement therapy. Renal biopsy should be considered if the diagnosis is uncertain, and an early referral for renal transplantation can be considered if there is no improvement beyond 12 months in cases that suggest that significant renal recovery is not going to happen. So, in summary, scleroderma renal crisis occurs in all subsets of SSC and not just the diffuse subsets. It may be a presenting feature of systemic sclerosis. Early detection and diagnosis is critical. Glucocorticoid use should be minimal. Prompt initiation of ACE inhibitors is important, and renal transplant should be considered in those patients requiring long-term therapy. Alternative diagnosis for AKI should be considered, especially if other antibodies are positive. This is my last case, and we have a 25-year-old female who has presented to us with complaints of fever, rash, joint pains, and symptoms that have worsened over the last 10 days. She has received multiple antibiotics because of these symptoms, has received tuberculosis treatment as would happen in our country, and has had a vaccination that is complete for age. She has had fever that have been intermittent and now have turned high grade and daily. Rashes, that is evanescent, non-pruritic and erythematous, has joint pains and multiple lymph nodes that are enlarged. She came to us with hypotension, very low blood body weight. I'm sorry, that was about 20 kgs. And her hemoglobin was suggestive of low hemoglobin. There was leukocytosis, thrombocytosis along with a high ESR. And this is what you would label as a case of adult onset Still's disease based on the clinical features that have been present. And this patient further deteriorated when she was with us. The hemoglobin fell, the platelets fell, the ESR reduced, the CRP increased, and the liver functions also worsened significantly. So in a coexistent disease like this, you would suspect this patient to have macrophage activation syndrome. We did a ferritin. The ferritin was at very high levels. The triglycerides were elevated. The fibrinogen was low normal. We did a lymph node biopsy that was just suggesting reactive hyperplasia. And prompt initiation of steroids in patients who have macrophage activation syndrome is very important. So as you can see, as soon as we started her prednisolone and cyclosporin, her reports, her ESR that had fallen started improving, her TLC that had fallen started improving, her platelets grew, and her liver functions that were very high improved progressively. So you have to have a very high index of suspicion for macrophage activation syndrome. Clinical features often overlap with a lot of other diseases. When do you suspect MAS? Look for a persistent fever with falling ESR. If you have cytopenias in any two lines along with an elevated ferritin, significant liver dysfunction, coagulopathy, and elevated triglycerides, you think of macrophage activation. The mnemonic is of 3 Fs. So if you have fever along with high ferritin and falling counts in ESR, think of macrophage activation syndrome. It has multiple causes. For us, it is important to recognize that infections is another very important cause of macrophage activation syndrome. Rheumatic diseases like lupus, AOSD, Sogia are again important. Very common infections like tuberculosis, staph, these are especially intracellular organisms that often create havoc in macrophage activation syndrome. There are scores such as H score and the HLH criteria that can be used for diagnosis of macrophage activation. And you have to act fast, treat with high-dose glucocorticoids. You reassess the patient in the next 24 to 48 hours, escalate to second-line agents, and consider targeted therapies like anakinra, JAK inhibitors, or empagliflozin if these patients are not responding in the next few minutes. And so I have discussed all of these autoimmune rheumatic diseases that can present to you with emergencies. We have discussed about catastrophic APS, pulmonary renal syndrome, rapidly progressive ILD, scleroderma renal crisis, and macrophage activation syndrome. And there are many more to go. So septic arthritis is another rheumatic emergency. So is lupus enteritis. I think Sapan sir did show a CT of a patient who has had lupus enteritis, and these again would require aggressive management. A patient that is presenting to you with gangrene, you have to decide whether this is a severe vasculopathy or vasculitis and can often be managed. To remember, a very important point is a female who's young to middle age and presenting to you with hypokalemic periodic paralysis should be considered as having Sjogren's syndrome until and unless proven otherwise. It is a very common cause of causing hypokalemia in patients with Sjogren's. You could have acute anterior ischemic neuropathy in patients who have giant cell arteritis. Atlantoaxial subluxation is something we have seen less commonly, but it is still happening in patients who have long history of rheumatoid arthritis, and CNS vasculitis can still happen. I could cover so much in the time allotted to me, but thank you so much for inviting me here. So these are all my teachers that have formed, and you would find all the rheumatologists that are sitting on this chamber in the image above. Thank you so much.
Thank you, Dr. Kunal, for the wonderful talk.